Done the same thing for many years, for decades, and that's typically bringing people in, diuresing them aggressively, and then potentially sending them home. And oftentimes, in my opinion, those patients haven't really been adequately diuresed or unloaded. A number of heart failure hospitalizations are actually a strong predictor of mortality. And so I tell people this is an important nuance to understand, is that every time you get admitted with heart failure, it's sort of a stair step that your mortality risk goes up, 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 up. And so the idea that, well, if I didn't diurese them adequately, discharge them, well, they'll come back if I didn't, get everything completely taken care of. If they come back within a week, they're a frequent flyer and we'll just do it again. You've actually increased that patient's chance of mortality. Early initiation seems to help establish euvolemia a little bit quicker. And there are some data to suggest that it decreases hospital length of stay. This isn't a huge leap, it's kind of common sense. If you start this on the front end and you know how much fluid you want to take off, which you can assess and you can dial it in and predict that, as opposed to putting someone in the hospital and treating with diuretics for 3 to 4 or 5 days, they're diuretic resistant, they still aren't mobilizing fluid, their creatinine is bumping, all those sorts of things. What can you do to avoid that? Well, it may be that you don't really employ that aggressive diuretic strategy on the front end. Maybe you actually think about doing ultrafiltration on the front end, which is something that we've tried to do. As at the end of the day, in my mind, one of the major goals of this therapy is that we're trying to avoid AKI as much as possible. It needs to get the fluid off and get them off a ventilator. And I think that just a common sense thing would say this makes a lot of sense. If I know how much fluid I want to take off. And what we've seen is that 60-day readmission rate, and granted, these aren't huge numbers, but we've seen a reduction of about 63%, which is even better than what most people would anticipate, right? So what we're saying is, if you remember back those slides, about half of those people at 60 days are going to be readmitted. Well, now we're saying we're dropping that number to a significantly lower level. Once again, changing the mortality profiles, the trajectory of that patient, and the overall cost, and hopefully saving their kidneys in the process. Impressed to say that probably our biggest advocates for this therapy are nurses right now, unequivocally. I think, one, they feel like they have some control over what's going on with the patient, which they do more than diuretics. But I think it's that they can interact with the patient, and the patient is seeing these real-time results of this bag filling up. I think they feel very empowered. I think they feel very comfortable. And I think it helps everyone to feel more a part of the treatment paradigm.